Hi everyone, it's Kevin Fenton here, the President of the Faculty of Public Health, and I'm so pleased to have a few minutes today to share this presentation on the future of public health practice, policy, and of course, the impact of prejudice. Now, many of you know that this theme is a topic that I'm particularly passionate about, given my work and commitment to tackling inequalities, but also my commitment to opening up the debate on different kinds of inequalities and different kinds of structural discrimination and how it impacts public health policy and programs. So, in the time that I have available today, what I'd like to do is to take us through a few things. First, I'd like to spend a little bit of time thinking about where we are in terms of the complexity in health and health outcomes that we're experiencing at this time and how they impact on inequalities and prejudice. We're going to look back a bit on experiences of COVID and what that taught us about policy and prejudice. And then maybe we'll look forward in time on our work on ending HIV transmission and how anti-discriminatory practices and policies form a key part of how we should be conceptualizing and designing our programs. And then finally, I'll speak a little bit about the work that we're doing in terms of strengthening our focus on equity in the faculty and what we all should be doing in terms of frameworks for tackling discrimination within our practice. So I'll cover this in the time that I have available today. So these are truly complex times for health and for public health. And many of you have heard me reflect on the reality that understanding our context is critically important in public health. We know, for example, that life expectancy is stalling across the United Kingdom and for the first time in a century. And we know that it is falling in some of the most economically disadvantaged areas as well. And we know that this stalling and falling in life expectancy is not randomly distributed, but more deprived parts of the country are experiencing greater change in the more affluent parts of the country. The rising tide of non-communicable diseases that has been happening over the past 30 years continues almost unabatedly, and more people are living with chronic major health conditions. So to the fact that by 2040, nearly 1 in 5 of the adult population in England is projected to be living with a major illness. And we know that for many populations, again, for many ethnic minorities and those economically disadvantaged, these chronic conditions appear earlier in the life course, and they're more likely to be experiencing multimorbidity as part of their health journey as well. Another important context is the widening of health inequalities that we've seen over the past 2 decades. And this includes and is being driven by a number of social and structural drivers. And this widening of inequality further exacerbates the risks related to morbidity and mortality as well. It is unimaginable that people living in the least deprived parts of the United Kingdom can expect to live to 70 years in good health, whereas those living in the most deprived parts of the country can only expect to live to their 50th birthday in good health. Now, add to the epidemiology of NCDs, we see the ongoing threat of communicable diseases, including the resurgence of a variety of childhood preventable diseases due to the falling childhood vaccination rates, for example, measles and pertussis, and of course, the threat of emerging infectious diseases beyond the COVID-19 pandemic to include new epidemics and manifestations of diseases, for example, Mpox, which we're currently grappling with a global public health warning. Now, our health challenges are situated within social and economic contexts and realities. For example, the cost of living crisis, which we've been experiencing since emerging from the acute phase of the COVID-19 pandemic, continues to impact vulnerable communities across the United Kingdom, with many families continuing to struggle to heat their homes, access healthy food, and having therefore an impact on physical and mental health. There are real concerns in government about declining economic productivity of our nation and the impact that that's having on people who are falling out of the workforce due to poor health, or people not able to function optimally in work because of their chronic conditions. And all of this is associated with changes in employment patterns, wage stagnation, and of course, ultimately, underinvestment in health and social services. Now, a real concern for the Faculty of Public Health is the rising rates of child poverty. Today, there are more than 4.2 million children, nearly a third of all UK children who are living in poverty, a significant increase since 2010, 2011, when there were 3.6 million children living in poverty. And we know that when we look across social, economic, and ethnic groups, we see very different patterns of poverty, as highlighted on the slide with this concentration among Bangladeshi, Pakistani, and Black children in the United Kingdom. Another key driver that I'm concerned about, and which is framing some of the challenges that we have with public health policy, programs, and practice, are ethnic inequalities in health. And many of these are persistent, pervasive, and have persisted across generations. We know that structural racism continues to underpin the poor health outcomes which are experienced by ethnic minorities, in part because structural racism has an impact on life chances, economic opportunities, social connections, and the ways in which communities are using, access, and experience our healthcare services. And in the slide, a chart on the right of this slide, we see the various different manifestations of these ethnic health inequalities in data from the Race and Health Observatory. So whether Black women in the United Kingdom are 4 times more likely to die in childbirth and as a result of their pregnancy than white women, the long-standing inequalities in coronary heart disease experienced by South Asians compared to the white populations, the concentration of specific thalassemias and sickle cell disease conditions, in Black and Middle Eastern populations. And of course, the high incidence and the burden of prostate cancer deaths among Black men, which has been well described and characterized over the past decade. All of these ethnic inequalities point to differences in socioeconomic status, utilization of healthcare services, and experiences of healthcare services, and as well as activation around health. And again, many of these are underpinned by communities' experiences of prejudice and social exclusion. So let's look at the data very quickly to just show some of the changes that we're seeing. This first slide looks at improvements in life expectancy and just highlighting the stalling which has occurred on the left-hand side of the slide when we look at life expectancy at birth for males and females between 2001 and 2018. On the right-hand side of the chart, we unpack the life expectancy data by deprivation deciles. And you can see the significant differences in the most deprived from the least deprived parts of the country, and the plateauing in life expectancy, which has been observed among all groups in more recent time periods for life expectancy trends. When we look at healthy life expectancy, some of these changes are even more acute. Now, healthy life expectancy, as you all know, is the average years of life lived in good health. And unfortunately, healthy life expectancy is not improving in England. And we have stark disparities in the numbers of years people can expect to live in good health between deprivation group. And on the left-hand side of the slide, we see for those living in the 10% of the most deprived small areas, they can expect to live 51.9 years in good health, with 26.4 years in poorer health. But contrast that to people living in the least deprived parts of the country, which can expect to live for nearly 20 years longer in good health, up to 70 years, with a more compressed period of morbidity, only 15.6 years in poor health. And many of the conditions causing these changes in healthy life expectancy are highlighted on the right-hand side of the chart. And you can see the preponderance of musculoskeletal conditions, mental health conditions, including depressive disorders and headaches, and of course, the impact of other chronic diseases, for example, diabetes mellitus as well. So these are all important drivers for health inequalities, and you can begin to see, even looking at the data, where policy and prejudice begin to intersect. Now, we are in the first 100 days of a new government, and part of what we have seen with the new government is a willingness to be open and honest about the scale and magnitude of the challenges that we face, a willingness to link health and good health as an asset for a nation, and to link improving health as a core part of our economic recovery and sustainability. and a clear series of pledges within the manifesto to both improving health care as well as public health and social care as part of a wider strengthening of our health and care system. And we are going to be looking at working and being an active part of both advocacy and partnership with the government in helping them to achieve the mission as part of our work and role in the Faculty of Public Health. Now, a number of the key manifesto pledges are going to be really speaking to some of the inequalities and contexts which I've spoken about before. You've obviously all seen and are aware of the manifesto pledges related to prevention, inequalities, and public health, especially relevant for work. A commitment from government to halve the gap in healthy life expectancy between the richest and poorest regions in England, ensuring that there's active action on tobacco-free generation, including the not being able to legally buy cigarettes for the next generation, really focusing on opportunities to strengthen tobacco cessation activities and with vaping, looking at high caffeine energy drinks for under 16, really thinking about healthy food environments, focusing on oral health, and of course on HIV as well. Now, there are many things that we should be looking at in order to build upon our experiences and to create legacies from perhaps our most recent experience where we've seen the intersection between prejudice and policy. And I'm going to use the example of the COVID-19 pandemic because for many of us, it's still rich, it's still present, and it's still impacting our practice in real ways. We saw very early in the COVID-19 pandemic the rapid emergence of inequalities, and that these inequalities were occurring across a range of domains, whether the disproportionate burden by increasing age, the clustering of disease and death in certain geographic urban concentrations within the country, the concentration of new diagnoses and death by deprivation, and the disproportionate burden by race, ethnicity. And many of these initial findings were summarized in the PHE report, which was done in the first 3 months of the pandemic, which really shone a light on the inequalities and spoke to some of the social and structural factors driving these changes. And clear among the report from Public Health England was not just the epidemiological manifestation, but in the work that was done to understand the why this was happening, we began to hear stories of communities not feeling engaged, of the role of structural racism, which prevented people from building trust and confidence in the messages from government. That fear and stigma of being diagnosed with COVID had a material impact on people accessing services and utilizing and being diagnosed with COVID. And of course, people's prior experiences of discrimination, of prejudice within the healthcare system meant that they were less willing to be diagnosed or to engage with the health service for potentially life-threatening disease. Now, there have been a number of studies subsequently to the PHE report which have begun to explore the relationship between COVID-19 and racial discrimination as an example of that interplay between policy and prejudice. It is clear that racial and ethnic discrimination has an impact on welfare state policies as well as labor market institutions, and that can disproportionately affect the prevalence and the burden of deprivation and poverty across ethnic groups. But we also know that racial and ethnic discrimination manifests itself in how people utilize the healthcare services and their outcomes as well, both in terms of pre-existing health conditions, which we know was a risk factor for more severe COVID. Discrimination can affect reduced access to healthcare if people are not trusting services or services are not reaching out to most vulnerable communities. It also affects the housing conditions that people live in, whether it is poor housing stock, overcrowded housing, or multi-generational housing, all of which were shown to be independent risk factors for acquiring COVID and having severe COVID disease. And of course, racial and ethnic discrimination has a role to play in where people work, the quality of the work, and the conditions in which they're working. And that unequal reliance on employment in high-risk occupations also had a material impact on the risk of acquiring COVID and, of course, dying from the disease. And therefore, it was perhaps unsurprising, although devastating, that in the early phase of the pandemic, we saw the disproportionate burden of disease among key workers, people who had contact with high likelihood of contact with members of the population, or high likelihood of contact with people who were infected with COVID, many of whom are Black and brown workers, or workers coming from more socially and economically disadvantaged backgrounds. Now, work has continued since then to really look at the lessons and legacies of COVID-19 and health inequalities. And it's clear that many of the lessons that we learned in COVID remain relevant today. These include the importance of taking an equity-focused approach to our work in public health, pandemic preparedness, and emergency response, looking at and developing our programs and policies through that equity lens to ensure that we're having inequalities at the forefront of our actions rather than as a secondary consideration. We learned throughout the pandemic that working in partnership across healthcare systems, including and working with the voluntary sector and the community and social care sectors, are critical for overcoming some of the challenges of policy and prejudice. And it's in that partnership and in the diversification of voices and perspectives that we have stronger programs. We learned in COVID about the importance of having great data that helps us to characterize the disproportionate burden among communities, that helps to shine a light on where racism and other forms of prejudice are operating and manifesting, and therefore to be able to evaluate the impact of our interventions. We also learned in COVID the importance of changing the research paradigm to ensure that we're developing more community-centered and community participatory approaches, that we're working in partnerships with affected communities, and we're answering questions which are meaningful not just to the researchers, but to the communities that are likely to benefit. And finally, we've learned throughout the COVID experience, again, the importance of community-centered and asset-based community approaches, absolutely critical for overcoming some of the ingrained and systemic prejudices that communities face by bringing communities to the table and inviting them to be part of co-producing solutions to tackle health inequalities. So there are many lessons to learn from our COVID experience. How do we bring them into today's practice, and how do we ensure that we shape our future health improvement and health protection work in ways that can build upon these legacies? Well, our experience with HIV really gives us an opportunity to ensure that those lessons are in fact enshrined. Lessons on data, on research, on partnerships, on community-centered approaches. And that's really important because although we are making great progress in our journey towards eliminating HIV transmission in England by 2030, we know that as we approach the elimination of HIV, we're going to be seeing further concentration of the infection among those who have poor access to preventive and testing services, among those who are socially and economically marginalized within society, and within population subgroups which have high levels or high prevalence of risk behaviors, whether high levels of unprotected sexual activity or high levels of injecting drug use or other risk behaviors. So it behooves us to ensure that as we are planning for our journey towards 2030 with HIV, that those lessons of tackling programs, policies, and prejudice becomes a key part of what we do. And this is important not because we're seeing concentration of the disease in different population subgroups, but we're seeing geographic concentration of the disease as well. So overcoming some of those systemic barriers to regionally and place-based approaches to responding to the epidemic will become important. It is also going to be important that we look at our data and become much more sophisticated in understanding where we're seeing differential impacts of our prevention programs and how we target and work with those communities to be more effective. So in this slide, we look at late diagnosis and probable exposure, for example, in London. And we can see when looking at ethnic groups that if you're Black African, you're 57%, your proportion diagnosed late of 57% is significantly higher than white and Black Caribbean populations in the city. And we can see that late presentation is not equally distributed by probable exposure category on the right-hand side of the chart, where we see a much higher proportion of heterosexual male and females being diagnosed late compared to individuals who acquired their infection through sex between men or injected drug use. These data are important because they provide us greater granularity to enable us to target our programs and enable us to shine a light on where inequalities are occurring. As we look towards 2030 with the HIV pandemic, we also know that global patterns of population movement and migration will also add to new HIV diagnoses. And here we see that increasingly we're seeing more individuals diagnosed with HIV abroad who are now migrating to the United Kingdom, coming from countries of higher prevalence. And this means having data that enables us to characterize the impact of population movement, and then to tailor our programs to ensure that we're culturally competent and engaging with people who are arriving in the country will be a key part of our journey towards elimination as well. Finally, in order to ensure that we're really responding and agile in our work on HIV, we have to ensure that that work centers people living with HIV and their needs in our efforts. And this is going to be a key part of the current and future HIV prevention strategies, that we are people-centered, that we're place-oriented, that we're data strong, and that we're developing culturally competent interventions for our work. A key example of this, again, taken from our work in London, is how do we ensure that we center our population work on HIV with people living with HIV. And this includes the way we commission HIV services, the kinds of partnership we develop, how we ensure that as we develop the range of interventions for tackling HIV, that we again engage with people who are at risk of acquiring HIV or who are living with HIV. And this includes whether we're looking at opt-out testing programs, whether we're looking at HIV testing programs and linkage to care, the psychosocial support that people will need, the ways in which we focus on tackling stigma, and the ways in which we encourage people to remain in care. All of this requires us to ensure that we're building in culturally competent approaches to our work. Now, in the final part of the presentation, I'd like to perhaps go from the specific to the general, to think about what we can do to tackle inequalities and prejudice, and what examples might we build on from our work on tackling racial discrimination and racism in public health. So many of you are aware that we've been absolutely clear in the Faculty of Public Health that it is absolutely important for us to tackle inequalities and prejudice. And this requires robust leadership, governance, and accountability. It is important that systems and our leadership are unequivocal in tackling inequalities and prejudice. It must be that we look at evidence-based programs to integrate anti-racism and to tackle structural discrimination in our systems and programs. And it must include the fact that we look at that intersectionality, especially with racism, between race and socioeconomic status, to ensure that we're tackling that intersectionality between poverty and inequality and root causes of some of the health inequalities that we see. And while we are looking at individual and community-centered approaches to tackling prejudice and racism, that we're also looking at economic inequalities, good wages, strengthening social care, and providing affordable housing as well. We also know that there are other things that will be important in this journey of tackling inequalities and prejudice, really looking at how prejudice manifests itself in health and care systems, improving access to and quality of and experiences of healthcare will be critical, to ensure that we're developing a variety of programs that are encouraging healthier lifestyles, prevention, and early intervention, but ensuring that these are culturally competent, appropriately targeted, and that we're co-producing them with affected communities. And finally, that we're supporting vulnerable groups as well. So as we are really tackling the prejudices and the differential outcomes for different population groups, that we are supporting and working with those groups to ensure that our services are meeting the needs. So a tangible example of this is the work that we've been doing in London to promote an anti-racism and approaches to tackling structural discrimination and racial and ethnic health inequalities. And this framework has been signed off by all of our healthcare partners within the city, with a core vision of all organizations working to improve health in London, opposing all forms of racism, and actively working to dismantle racist and discriminatory policies and practices across the health and care system as we work towards racial equity. Now, a key part of the framework involves a number of key steps. First, that the leadership of our health and care systems are visible and anti-racist, and that there's board-level review of strategies and monitoring of the objectives, programs, and indicators on our journey to become anti-racist. Second, that we work with the healthcare workforce or HR policies, tackling bullying, harassment, and discrimination, providing training and support to address cultural bias and discrimination, and including creation of safe spaces, and that we protect and support our workforce through implementing and monitoring robust equality, diversity, and inclusion policies as well. And we use our data to monitor the experiences of our workforce. Third, our approach in London asks for programs to really prioritize health equity activities and programs and to embed the anti-racist lens on programs such as Core 20 plus 5 and the Marmot framework, and including data-led insights to prioritize area of work along with our communities when it comes to which programs get prioritized to reduce inequalities and embedding our anti-racist approach in those programs. Fourth, our approach in London builds upon our experiences of the benefits of NHS and other organizations being anchor institutions and therefore contributing to racial and ethnic inequalities by their ability to tackle those wider determinants of health through their work as anchors, providing employment opportunities, education and training opportunities, apprenticeship opportunities for local communities, and in providing an opportunity to really help local communities to tackle some of those wider structural determinants of health. And then the fifth pillar of our work in London is to work with communities to rebuild confidence and trust, recognizing the importance of the community's voice in helping to develop culturally competent programs, to embed best practices on co-production, and to be able to support community organizations through resourcing to be stronger and more meaningful partners in tackling health. Finally, another example of the work that we're doing in the Faculty of Public Health when it comes to tackling policy programs and prejudice is again our anti-racism framework. And in this framework, which we've developed in the faculty, we hope to guide other organizations in their work to develop anti-racism strategies and to be leaders across the medical colleges in this space. And the faculty's anti-racism approach is built upon four key commitments. First, that we will recognize that structural racism exists, that it's harmful, and that we will protect our staff from its impacts. Second, that we will continue to work to redress racism and to call out structural discrimination. So being a real advocate and a clear voice of leadership on the public health crisis that racism and structural discrimination creates. And third, that we're going to be transparent and accountable and that we will measure our progress on our work. And fourth, that we will use our unique position to influence the public health workforce and the wider community as well. And hopefully many of you have seen the ways in which our anti-racism framework is being manifest, both in terms of the conversations that we're stimulating on anti-racism, prejudice and structural discrimination, the work that we're doing on fairer attainment, both for our exams, on our training experience, and of course, our work on well-being for the workforce, where we're actively looking at ways in which we support all of our members to have fulfilling and productive careers in public health. These are all part of the work that we're doing to tackle sort of ingrained policies and prejudices in the workforce. So colleagues, this brings me to the end of this brief presentation today. I wanted to reflect on our work on this and why public health legitimately is in this space of understanding policies and prejudice. We focus on using a number of examples, both from COVID-19 and our work on HIV prevention, to show how we can move from the theory of tackling racism, structural discrimination, and prejudice into policies and practices that really matter. And then finally, we've looked at frameworks, both from the health and care system in London, as well as from the Faculty of Public Health, that provide steps and tools and pathways for operationalizing and actualizing concerted and impactful action in this space. I hope this has resonated with you, and I look forward to hearing about the discussion and the debate that I'm sure will follow this presentation. Thank you so much, and I wish you all the best for the rest of the meeting.